Thank you for joining us today for our AI in Action webinar. We're looking at triage and patient flow, AI applications in 111 and A&E. Next slide. So I'm Carla Richards. I'm one of the senior project managers at the Health Innovation Network in South London, and I'm also an NHS navigator on our Digital Health London program, and I'm really happy that you joined us today. Slide, I think we've got our agenda. So we've got a couple of really good talks for you today. We have Dr. James Ray from NHS England, who's going to be talking about a pilot they ran on 111 services. And we have Dr. Ahmed Mahdi, who's a consultant in emergency medicine at St. George's, who's going to talk about the use of ambient voice technology in A&E. And then at the end, we have a Q&A panel with the two speakers and with representatives of the technology that they've been using. Next slide. So this webinar is brought to you today by the Health Innovation Network. So the Health Innovation Network is a sort of network of networks across England. And we're really involved in the adoption of health innovation. You can see some of the stats here across the screen about the number of patients that have benefited from our programs, how we've helped reduce capacity for staff, and also the economic impact of the innovations we've supported. More than £3 billion of investment since 2018 across the whole of the Health Innovation Network. We've safeguarded lots of jobs, we've increased the numbers of opportunities for these businesses, and we've seen a 3-to-1 return on investment through our innovator support programs across the whole network. Next slide. So the Health Innovation Network, like I said, it's kind of a network of networks. There are 15 health innovation networks across the country, and we each cover a different regional area and set our own priorities for work based on where we're located and the health and social care system in that area. So you can take a look here and see where you're dialing in from, what your local area is. If you're an innovator, these are great organizations to get in touch with support for your programs and your projects. And if you work for the NHS or social care, each one of these organizations can give you some advice and suggestions if you're looking for digital solutions or you're looking for new innovative ways of running your pathways and your operations. So I'm from the HIN South London, which you can see kind of in the bottom right-hand corner of your screen. And it's one of the 3 health innovation networks in London. And next slide, I can show you a bit about what we do at the HIN South London. So the way we're set up in South London is we have our different themes, we call them. So you can see here, we work in mental health, community and care homes, long-term conditions. We've got an evaluation team. We have an innovation team that works and does our innovator support, patient safety experience, and our digital transformation and technology team. So these are the kind of main areas that we work in, and these are priorities that have been identified with our South London partners. Next slide. I sit on our innovator support team, and we run what we call our Digital Health London programs. And so the 2 products you're going to hear about today are both companies that participated in our most recent Digital Health London Accelerator program. These are pan-London programs where we pick what we think are the best new technologies and really help with the spread and adoption across London and also nationwide. So you can see some of our partners here. We get our funding from the Office for Life Sciences, and also we get support from the Mayor of London and our partners, including CW+, which is the charity at Chelsea and Westminster Hospital. Next slide. And I'm just going to give you a quick overview of our programs before we move to our speakers. Our kind of flagship program, which I mentioned a moment ago, is our Accelerator program. And this is a very competitive program. It runs for 12 months, and we give intensive support to the companies that have been selected. We also support our NHS staff through our Digital Pioneer Fellowship. So this is staff that's leading digital transformation. Our Launchpad program is for companies that are early stage looking to launch to the health and social care market for the first time. And we have our Generator program, which is specifically looking at evidence generation and digital transformation. And next slide, we've got some of our more recent programs that we've been running. The really exciting one is our Accelerating Femtech. Applications are open again now for the next cohort of this program. So you can go to our website and get more information if you are running a Femtech company and like to know more about that. LEAP was the program that we ran for our diverse founders. We ran a program for social enterprises, and we recently had a program to support digital health companies learning about net zero and how that would affect their work. And so if you'd like any more information about the Digital Health London programs or about the Health Innovation Network, please do get in touch. There'll be some contact information at the end of the webinar. And so with that, I'd like to hand over to our first speaker. And we have Dr. James Ray, who's the National Clinical Advisor for Urgent Care from NHS England, and he's going to present the pilot they ran and the 111 services. Thanks, James. I'll hand over to you.
Thanks, Carla, and also thanks, Emily, for doing the slides. So I'm James. I'm an emergency medicine consultant based in Oxford, and I also look after London as a regional lead for digital and IUC, which is integrated urgent care, and I'm one of the national clinical advisors for urgent and emergency care. So if you go to the next slide, please. So what I'm going to be talking about today is the background of the problem and why we thought about using Viziba triage within London 111 service, what the project's based on from a patient and clinical experience side, what the outcomes are like, and finally a little bit about strategic commissioning and really people who are interested in health economics, how we can really save and protect our patients in the future. Okay, next slide, please. So one of the challenges is today in the NHS, patients who have a same-day clinical need, they decide on what services that they make that first contact with. Next slide, please, Emily. And what we see is the distribution of those first contacts are really, we know that about 80% of people are contacting their GP. Around 10% go straight to A&E and about 10% call 111. But actually what the reality is a lot of those patients that actually call 111 might be end up in A&E. We know that a lot of those patients who contact the GP end up in either 111 or A&E as well. So that is and this is sort of based on real data, but that's the reality of that first contact. That's the point in this slide. Next slide, please. And what we want to be able to do, and we know that about 40% of patients present to the wrong service. We want to see how we can improve that with intelligent navigation. And this is also supported, if anyone's interested, there's a paper that was written by the Tony Blair Institute, which also agreed and concluded with the same conclusion and thought that intelligent navigation needed something else to support understanding what the patient's needs are and how we can meet those needs on that first contact. Next slide, please. So if we wanted to look at this in a sort of a better way, instead we want to be able to potentially use knowledge of the patient and also the use of AI, and explain why that's really key compared to the service that we use at the moment. Try and get patients to that right service on the first time. And if we did that correctly, we'd be much more realistic with those outcomes. So we'd see a much more reduced amount going to same-day GP, which would be hopefully more between 20 and 25%, and a higher proportion of patients that think they've got a same-day need could be booked into a more routine service within day, 2 days, week, etc., based on the assessment, and also utilise services that exist for those 7 conditions. Pharmacy First, which we know is a fantastic resource and significantly underutilised. And then using 111 more appropriately, and of course sending patients to the emergency department when they need it, which hopefully will be more like sort of 5% of patients as opposed to what we're seeing at the moment. Next slide, please. So we introduced in London Viziba triage, and what we wanted to do, this. It's really challenging to look at new technology when you're dealing with 10,000 plus undifferentiated patients calling in a service on a daily basis. So we introduced it through a specific pathway, and that pathway was aimed at patients with a skin rash, which is the first pathway we decided to use. And we wanted to we looked at the numbers based on the numbers of these patients were calling 111 currently, and that's how we modeled it. And then we put them through a triage, and those cases then went to a clinician with a lot more information based on the AI triage into the clinical stack, so the clinicians could then deal with those cases. So if we go to the next slide. So essentially, if you press play on this, a patient will call through 111, and based on the reason for their call, the IVR and the actual the telephony platform can pick out whether someone is calling based on specific parameters. And we also use natural language processing. And if they accept the call and they want to go through this smart triage process, they would be sent the link, and then they would go through this triage. Which is really easy to use, and I'll come to that, and hopefully through the Q&A we'll get a little bit of this. But the people that used it found it very easy. They put in their information. You're able to put a lot more information about your symptoms. It really flows and what you're saying the problem is, and it's using your language. And it's basically, you can put as much information into that triage as possible, because it doesn't have that kind of process, which is a single layer, single clinical symptom pathway. And you can also upload a photo, which is really helpful, and that photo can be used within the triage process which is powered by Red Robin, the AI actual algorithm based in the background. And then that would then go through to a clinician. So if you go through to the next slide, that would then sit in the clinical queue, and the clinician would see the picture of the patient. It would have a more realistic outcome, a prioritization of 1 week in this case, which is an urgency level 6. It would also give you a differential diagnosis. And what we did do with our pilot is we actually asked the clinicians to do a conformity of what they felt, how close to the differential diagnosis they felt this was. But what's great about the AI, it's not black box technology. You can actually interrogate it and find out what were the actual key questions or decision points that led to the differential diagnosis. And it is also tweakable if you feel that it was under or over triages these cases. So it was a really, really useful process. But this is what the clinicians would see. So if we move to the next slide. So then we're going to go to the impact. So we evaluated the process through over 3,500, well, around 3,500 patients, and we found that with this process, 55% of the people that went through the process didn't need any further treatment. They were consulted and completed, because the clinicians within the CAS, the Clinical Assessment Service, can also prescribe. They can also just give advice, etc., and send information to the patient. The numbers of ambulances that were triggered were a lot less compared to our control group, significantly, and also for the patient, it was 30-minute less saved for them, because it wasn't going through this long multiple question process. And when we looked at patient acceptance, we had a very high acceptability by the patients, which is really exciting. So our evaluation was very successful, which led to London taking significant interest in pushing this further. So on the next slide, I just want to sort of mention, because when you're dealing with a system and a service that's taking 10,000 plus calls a day, it's really key to look at how we can potentially get patients to the right place, how we can commission the service more appropriately. So the modelling for this commissioning in currently that's been put into North East London is looking at how we can improve the proportion of cases that go through AI versus telephony, and that's going to be staggered over the years. And then what we'll see is more capacity entering the call handling element of the service. And rather than diminish what 111 does, we could potentially then use that capacity to support other services such as primary care. But with this, and you can imagine that by actually getting much more outcome data and interrogating the patient journey, the patient notes, and seeing actually what happens to patients, you can really start to see that the benefits of that you could, or which particular cases you could grow this on. Our initial thoughts in London were looking at things like upper respiratory tract infection, people calling in for common things like gastroenteritis, and we also, through our NLP platform, we now know what types of cases are ringing 111, and we've put them into about 183, 185 groups, and we can start targeting those groups really quite clearly by using our NLP and our platform, which uses a CRS platform, or what we call a PRM. And then the next slide is it's just me saying thank you. And I think I was quite limited on time for that, and it's hopefully a short snippet of what we've done in London. There's a lot more to it. There's a lot more. Hopefully, things will come out in the Q&A. But the strategic view of London is to now develop ways of using this particular product and other products similar to this to actually try and get patients into the most appropriate services. So I'll leave it there, but thank you for letting me speak, and I'm hoping that we can talk more. Someone said, sorry, PRM is patient management service. So it's I'm just trying to think what R stands for now. If anyone
Relationship, I think.
Relationship, patient relationship manager. It's a bit like a CRM, but what it does when a call comes in through 111 on that platform, you can then take patients that are a specific criteria. If they're under 5, if they're a particular age, or if they're a particular group of patients, and then you can then sift patients away. And also we can divert patients to different parts of London, because there's 5 ICBs in London, so we can actually send them to the most appropriate providers. And that's the function of the PRM. There's so much more to it than that, but that's essentially what it is.
Thanks, James. We have a few questions in the chat, and we've got a little bit more left in your time slot if you're happy to answer those.
Yeah.
The first question is from someone from Croydon Health Services, Yukiko, who asked, and I was going to ask this too, is the Pharmacy First program being promoted on social media? Yukiko says that they haven't really seen it in public media as such.
Yeah, it's a really, really good point. I mean, we are really strongly trying to promote the Pharmacy First program, which is based on 7 common conditions which pharmacists can now prescribe for. What we're hoping to do is to look at how we can get patients into those services. I mean, obviously advertising and social media is really important, but it's still being referred to a service is also quite powerful. And if you're able to divert patients from the emergency department, from primary care, or from services like 111 directly into a booking process within Pharmacy First, you can imagine that would be really successful. But it's really hard to do. It's difficult when you go through ED to actually, by the time you've assessed them and seen them, realize that they're low acuity and they probably would benefit from, you've almost got to the point that you probably could sort them out. So you need to be able to do this very quickly, very slickly, and probably a digital solution is probably the way forward. So if a tool was able to then, if you were low complexity patient, so if you didn't have background health, long-term conditions, etc., had a sore throat, you could probably be then directed straight to a Pharmacy First appointment. That kind of thing is where we're looking at. But social media is one element to it, but there's a lot more to it than that, I would say.
Great, thanks. There's a couple other sort of related questions. The first one is, someone has asked, what's the expected time frame for a clinician to review a 111 case? And I suppose maybe, do you know the time frame without using the Visiba triage system and the time frame with it?
So this is a really, really good point, because what happens is when you go into the clinical assessment service from 111, you sit in a prioritisation queue. So you're either a P1, P2, P3, and however you've commissioned or set up that service, a P1 could be 30 minutes, could be 50 minutes, and etc. And a P2 is set at specific particular timeframes, which is supposed to meet as part of your KPI. But the challenge is within an undifferentiated queue, some patients sit in P1s that probably aren't P1s, which we know, and it's finding those needles in the haystack across a huge queue of patients. And what I really like about AI is, and what the clinicians found from the CAS, the clinicians that use this, is by having this information that's really easy to read, even having a photograph if necessary, but just a lot more detail, you can actually pick patients out that really need that prioritization quicker, and you can understand those patients. And if you can imagine that particular patient, that example that we saw, there's an opportunity really for a clinician to see a case like that, trust it, and potentially then send a message to the patient using something like AccuRx or something similar, and say, here is your this is what we think you have, here's your prescription, if things change or worsen, please seek help with your local primary care provider, or something like that, where you could end the case without having to go through that conversation call again. So the opportunity for reducing call demand from the clinical assessment service for the future is going to be really significant.
And there was a clarification question. If a patient contacts 111 without a smartphone, they would just go through the kind of old-fashioned regular
standard. Yeah,
standard.
they go through the standard.
That's probably better.
Yeah,
Standard,
absolutely.
Standard. And great. Someone else asked, is this service had an impact on your conveyance rates into hospital?
Yes, it had on the evaluation we did, we had a reduction in the patients that were sent to ED and a reduction in the patients that had ambulance disposition. So, and that's what we would aim for. That's ultimately what we're trying to do, is reduce that demand into higher acuity settings and get patients into more appropriate settings in appropriate timelines, not just within 1 hour, 2 hours, which is what's happening at the moment, which is forcing patients back into primary care when they're already under a lot of strain.
And related to that, there was a more of a comment in the chat. Someone wrote, would the skin rash baseline for an ambulance ever be 10%? I think you just used skin rash because it is a good example in your video where you can show photos and things, but you do triage other conditions.
Yes, I mean, skin rash was the first one we started with. We moved beyond that, but it was a safe, sensible starting point that everyone felt. Although there are a lot of very obviously high acuity illnesses that are associated with skin rashes, so that's also got to be considered. We went through all that through our governance process in terms of how to make sure we're not missing meningitis and various other things. So that was another key part of our process prior to setting it up and agreeing, and the go no go process.
And in relation again to skin rash or other conditions, the photographs that people sent in, did the pilot include all different of skin types, skin colors, and were the outcomes effective for different ethnicities?
So that's again a good question. The Visiba model is based, obviously Visiba was developed in Sweden, and I would say that if you look at companies like Skin Analytics that are using AI for it's now a class 3 device that can actually diagnose and treat and basically recognize cancer versus non-cancer, and that is based on all skin types. That's the direction I think we want to be going in, that it doesn't matter what color the skin is, it will pick up the problem.
And one last question that's actually made me laugh a bit. The person wants to know how the app actually understands the patient's words or intentions to triage. This comment says that it's amazing because my Alexa doesn't understand me many times. It's all text based, isn't it? It's not.
It's text based. Yeah. I mean, you could move it to speech based into text form. And there are different ways of doing it, but we decided to go down this route of using text. Because it's just easy to upload, and you could just put in single words. It doesn't matter the kind of number of words you put in, it works all that out. So like when you use ChatGPT, it doesn't matter what you put in, it just kind of works it through. But I think people, the interesting thing was the acceptance from the public. The people found it really useful, and that is, it was kind of above industry standard in terms of the level of acceptance we got from the public, which we also discussed in a regional meeting which had the public, patients and providers of healthcare, and it was, people generally want to do something different like this because we know the challenge of waiting on the phone. And then going through a long triage on the phone is quite, for some people, not that acceptable at the moment.
Great. I think we're going to move on. I can see there's a couple more questions. I'm making note of those. We do have a panel session at the end that I think actually these questions will be good for. And so if we can move on to the next slide, I'm pleased to introduce Dr. Ahmed Mahdi, who's a consultant in emergency medicine at St. George's, who's going to talk about their use of ambient voice technology in A&E. And he's going to share his own slides. So let's see if we can get those switched over. Cool. And get those popped up. And there we go. Great. Over to you. Thanks.
Thanks, Carla. Yeah, so my name's Ahmed. I'm one of the ED consultants at St. George's. Thank you very much for inviting me to talk about our project that we did. Forgive the cheesy title. As you know, St. George's has been home to 24 hours in A&E. So the fundamental issue that we are all aware of, waiting times within the ED are getting worse. There's increasing pressure, issues with flow, and there's a huge kind of financial burden amongst the NHS. So what I wanted to do is, first of all, evaluate, does this kind of technology actually work in the emergency department? It's a very challenging environment, a lot of additional background noise, multiple patient reviews. It's not a linear kind of journey most often with patients. So what we wanted to do is focus on these 3 key KPIs. So does using this technology allow me as a doctor to see more patients on my shift? We also looked at how quickly it was for us to do our clinical notes. And I wanted to kind of review any kind of surrogate marker to improvement of flow. So the time when I assign myself to a patient to when a decision when they're clinically ready, which effectively meant I've discharged the patient, or I've booked, or an inpatient bed is booked for them, or transport was booked for them. Does it make a difference to the flow of patients? So we focused on time-stamped time entries on the electronic health record so that we minimize bias through observer statistics. We also looked at the cognitive impact in quite a lot of detail on ED clinicians specifically. So we undertook validated surveys before, during, and after, and also had one-to-one interviews and group interviews in quite high depth. So that's what we looked at. So the actual process of going through everything. So we had 24 clinicians enrolled. It was a range of experience. We looked at data before, which was at least 2, most of the time 3 months before, and during the pilot. So we looked at 3 months worth of data. There's quite a lot of training involved. We used a combination of different techniques, which included face-to-face, lots of e-learning modules, some videos, and a WhatsApp group, which was quite invaluable, particularly in the early stages. We undertook some statistical advice, and the target was to get 1,500 patients for our study. So our results. So go through these all in a little bit more detail. So we got a lot of patients. We got over 4,500 patients. And there was really good improvement in all KPIs. So we'll just break things down one by one. So, yeah, I think the key goal is, as a doctor, can I see more patients in the ED? There's always patients waiting to be seen. Every clinician showed a significant improvement in how many patients they saw. The average increase was around 13%. So you can see on this graph that there was a range of percentage increase. There were some clinician groups which performed really, really well. So these were amongst the emergency practitioners and the GPs. As often they would just see the patient and not require any additional further investigations or reviews. But again, they were statistically very significant. So really good uplift in the number of patients seen. Then we looked at the time taken to document our notes. So within the ED, patients often need loads of inputs into their electronic health records. But the first clinical documentation usually is the bulk of the entry. It carries most of the history, the assessment, the initial plan. So we looked at only the first clinical entry. And again, everybody showed significant improvement, a 51% increase. We did analyze the data for all the subsequent documentation episodes, but there were just so many variables that we wouldn't be able to extrapolate any meaningful data from it. So for example, I'd send a patient for a CT or an X-ray or wait for additional bloods. There was so much variability that you couldn't decipher, but the bulk of the clinical documentation was obviously a lot quicker. And then the last one, when I assign myself to when a decision is made that the patient is ready to leave or needs a bed or can be booked transport, showed an improvement of 7%, again, statistically significant. On this KPI, there were 2 clinicians where there was a reduction, a very minor reduction. These were amongst the more junior doctors. This is a surrogate marker for flow, I think, and it suggests that the use of ambient voice helped the flow of patients. So the clinical experience. So like I said before, we undertook quite a lot of detailed analysis on how does this impact in our workflow. Obviously a new technology, we want to understand this a little bit more. So I was really surprised at how amazing this was to the cognitive kind of offload to clinicians. So the headlines are there were massive improvements in being able to give patients more attention, better overall experience, found it a lot less stressful, less disruptive, and they were just way more satisfied at checking the output, reviewing the notes rather than inputting everything. Interestingly, there wasn't any difference in terms of how satisfied clinicians were with the accuracy, completeness, or the relevance of the notes. And this is summarized by the fact that only 6%, as opposed to 71% of the participants, felt that they were kind of overwhelmed by the process of note-taking. And just going a little bit more in depth with that, so people describe note-taking as quite stressful, busy, and tiring, and afterwards it was a lot more efficient, easy, comprehensive, time-saving. So furthermore, looking at the cognitive aspects, so we undertook some kind of validated scoring. The Net Promoter Score, which was 52, this is, if you're not familiar with, a very, very good score, and it implies that using this technology is not only useful, but quite safe and supportive. So I'll put this next bit. So it's not just a click away. I just want to go through a little bit more detail about the good, the bad, and the ugly. So related to the cognitive improvement, I think there's a huge scope to look at this in a lot more detail. What impact does this have on burnout and sickness? If I'm cognitively fresher, I'm less likely to make bad decisions. So what impact does this have on clinical incidence? A proportion of our participants were neurodiverse. They found this even more helpful than most. So this is a really good avenue to look at as well. Improved communication with colleagues. So most of us within the ED, unfortunately, will stack our notes to write them as we go along because of our time pressures. Writing notes as we go along is best practice. It's obviously much better for the patients and the flow of patients in terms of referral to specialties. Often the specialties will come and say, yeah, I can see what you've done with the patient. It also generated a standardized GP summary, is really important for communication to our colleagues. It'd be very interesting to look at reduction in reattendance rates or complaints. Another really important element was most clinicians got up to speed after a couple of weeks. This is really important because you don't want to hit peak productivity with most clinicians working in the ED have rotation times of like 4 or 6 months. So the bad elements, so the workflows that we used amongst the pilot, I think can be improved. We used a microphone. There was often very limited range of the microphones because of lead lining of the walls. The cost of the microphones are quite a lot. I know there obviously can be alternatives, and the output wasn't integrated within the electronic health record. But even with that, you can see how such a great improvement was in our kind of workflow. And the other bit was changing clinician perception. There was a few reservations by some of our colleagues about using this technology. There wasn't any patients who objected. All patients were very positive and recognized that this is a tool to help them and help us as clinicians. And I think the real big question next is how do we mass deploy this well, and how do we do this effectively and quickly? Because I do think this is a game-changing experience for ED clinicians. So I'll just end to say that ABT I think is the tip of the iceberg. For me, I cannot see myself not using this technology again when I see patients. I finish my shifts on time. I don't stack all my notes. I feel a lot fresher after my shift. I think the next steps are really, really positive. We can then start working on automated discharge summaries, direct ordering, supporting our nursing colleagues, coding correctly, integration, and collecting data sets. So I think this is really good stepping stone. And like I said, I think the main question here is how we mass deploy this really well amongst emergency departments. I think it's a very exciting time. So that's the end of my talk. I'll hand over back to...
There's a couple of questions in the chat for you. The first one, someone asked, what was the name of the technology you were using? I'm not sure if you mentioned that you were using Tortoise as your ambient voice technology.
Yes, that's right. So Tortoise supported this pilot as part of a wider trial with GOSH, looking at lots of different clinical areas. So it was through Tortoise.
Great. And then there's another question. The clinicians that were using Tortoise, were they using it to capture the consultation, or were they using it to summarize their notes, more like a dictation?
So what was really interesting, within the ED environment, you've got a whole mix of different patients. So some patients got significant delirium, confusion. You're not able to get a good history. Some patients are quite straightforward. Sometimes there was a lack of feedback for the microphones. But what we quickly found that clinicians become very adaptable depending on the scenario, on the environment. So a whole combination of things were used. So it would be a direct consultation sometimes. It would be going back to the base station and dictating. And I started using it in terms of education as well. So I would ask my resident colleagues to review a patient and come and discuss with me straight away. It would listen to our interaction. It would produce the whole summary. It allows me to unpick the history in a lot more detail. And it's so much better for the resident and myself because I can give direct feedback, direct teaching. So what's really great about this technology, it's versatile. And that's where the training and the nuance really comes in terms of mass deployment. So to learn all of these things that we've gone through to empower clinicians to have that slight shift in how their workflows are, to make them work better, feel better. If that answers that. Yeah.
Thanks. And then I'm gonna roll through the questions into one. There was a question about integration with your EHR, your electronic health record. There was a question about how you got over IG hurdles, and then there was a question about how did you consent patients. I think they're kind of all related.
Yeah. So information governance, we went through a rigorous process for approval. Tortoise, their product does not store any information. It doesn't use the history to kind of relearn and improve itself, which from a governance point of view, obviously is crucial. So we had formal approval from information governance at our trust. The other question is integration. So what we did was copy and paste into the electronic health record. Now, I think for a pilot feasibility study, that this was completely fine. It acted as a bit of a stop check just to make sure we're writing the right patient notes. I think, as you can see, the productivity is great. I think in the future, integration is important, but it's not the be all and end all. But I think it's the way forward, and it would even better optimize, your productivity. But with that requires another layer of governance and tight workflows to ensure that you're pulling the right consultations into the right patient notes.
Great, thanks. And I think that's probably a good point to maybe have Emily pop the next slide back up from the other presentation and move into our panel discussion. Because I think some of the questions they're coming fast and furious in the chat, and I think some of the questions relate to both technologies that we've heard from. So I'm going to just show this slide quickly, and then we'll take the slide down. We'll have a quick panel discussion with Dr. James Ray that did the first presentation, and along with Hannah Gibson, who's the representative from Visiba, and Dr. Ahmed Mahdi, who just finished, along with Dr. Don Pimenta, who's from Tortoise. And I think that they can probably answer some of the questions. So we want to maybe pop this slide down and highlight them. That's fantastic. So I think I've been writing some questions down. There's quite a lot of questions in the chat. I think the first question that I'm going to kick off with is, what would you say is the main difference between using, for example, using Visiba instead of the old 111, or using Tortoise instead of the traditional way of taking notes? How is that AI technology, what would you say is the single most, the biggest change or the biggest difference that you've seen? Don't know who wants to kick that off.
I could go. So I think for me, the biggest difference is, I suppose, one relies on a telephone consultation process and using an algorithm which you specifically have to go down a kind of symptom route, a symptom group route. And sometimes what we do see is people get put into symptom groups, and it's almost like a Procrustean process that you get put into a specific group. And when I see these patients in ED, I'll appreciate that they're not always related to the reason for the problem. So they might come in with chest pain. Actually, what they've actually got is vomiting, and indigestion, etc. So whereas and also the time of the, so obviously the Zebra will use multiple entry points and be able to there's no limit in terms of what information you can put into it, but it's a much quicker process rather than having to go through a long telephone call process, if that makes sense.
Yeah. And Ahmed, what do you think, from a clinician point of view, the single biggest difference in your way of working?
So the biggest difference to me, so we all know it makes me see more patients, but honestly, the feedback that we've had and the experiences I had, the most important thing is the cognitive offload. I think look, every emergency department sees hundreds and hundreds of patients. We have no choice. We have to go through everybody. And using this tool allows me to safely review these patients quicker and see more patients. But I think we all underestimate that EDs are overcrowded. There's patients all across the corridors. We unfortunately have mental health patients all around us. While we're still trying to do the administrative notes, offloading all of that, okay, has been, has had such a massive impact on, my feeling at the end of the shift. I feel fresher, I feel better, I feel more satisfied in every way. And in a day and age where technology is seen as a kind of threat of taking away our jobs, this has actually allowed me to do my job better. I can speak to patients. I think one of the GPs within the interview said, you know what, it was quite refreshing for me to actually look at the patient while I'm taking a history rather than looking at my computer. He said they felt better, I felt better. It was win-win all around. So for me, it's the cognitive offload.
Super. Maybe a question for Hannah and Dom, kind of looking not just at these two pilots, but looking at the adoption of your technology in multiple places. Have you been able to note any changes in the rates of patient safety incidents or reports that have made? I don't know if this is something that you've measured or not, looking at using your technology as opposed to the kind of more manual way of doing things.
Yeah, I can speak to that somewhat. So maybe actually more relevant for Hannah. The only thing I was going to say is I know for a fact that a tortoise note has gone to a coroner's court, and the organization was very happy because it was more detailed, it was very thorough, it completely covered the conversation with minimal lift. And I think the medical legal aspect yet to be tested really, but certainly seeing that people feel a lot safer with that volume of information. One of our users went back, he's done about 8,000 consultations in primary care now over the last year, looked back his notes before using this technology and just felt very unsafe about those notes as opposed to what he has now. But again, I think it's quite early days.
Yeah, and I would say we've never had a clinical incident, but in a way that's an unhelpful thing to say because it's a when rather than an if. I think anybody deploying any technology in this kind of setting will do. So it may very well happen. I think the challenge we've got now is there's not really baseline data because of how the NHS handles and has had to handle navigation and the front door. So for example, if you phone 111 or if you phone your GP practice and you're struggling to get through and maybe you present into multiple different settings, it's very difficult to tie together that whole patient experience to say, okay, this person had an adverse outcome as a result of X, Y, and Z. It might happen within a specific service, but not across the whole journey. So we've never had to encounter this. We think we probably will at some point, but I would also draw attention to the fact that we need this data at a system level as well. And there are a couple of studies ongoing at the moment that's looking to pull that together. Super.
Maybe kind of a technical question. I might start with you, Hannah. first of all, I'm assuming that both technologies are certified medical devices just because of the kind of work that you're doing. But what's the difference in Visiba, using the Visiba AI technology as opposed to sort of a decision tree that one might encounter on a website or at the GP practice?
Yeah, so we're a Class 2A medical device. So that means we've been externally audited. So Class 1 is a self-certification. Class 2A, you're externally audited. The difference there is that it doesn't necessarily mean that your tool is appropriate for a higher degree of risk. It means that it's been audited for your intended use. So there is something there that it's worth understanding around medical devices. If anyone's interested, I'm happy to have that conversation offline because I do think it's quite important. Sorry, Carla, what was the second part of your question? I've completely forgotten now.
The sort of difference between the AI technology and a decision tree that one might come across.
Sure. So we are a Bayesian network. So specifically, it's a medically trained probabilistic graphical model. Again, if anyone's interested, happy to show you what that actually looks like. What it means is that somebody could tell us, okay, I have these 10 symptoms, and the model is going to collect together multiple symptoms, multiple nodes, and try to understand the most likely differential diagnoses and the urgency in the fewest number of questions possible. So a decision tree will, I mean, we all know what that looks like, right? You answer a yes or no, and you go down a pathway, and you tend to be driven by one symptom. And that works quite well for quite simplistic presentations. But when we start to talk about complex presentations, that's when you get significant over triage, slightly trending towards more acute presentations. So you see patients maybe with unnecessarily ambulance deployment. So in 111 now, I think the data is that 75%, I was in a meeting recently, they said 75% of ambulance deployments are subsequently downgraded once a clinician looks at them. And that's a result of a decision tree doing what a decision tree does very well, which is just making sure people don't slip through the net necessarily. Maybe James.
And kind of a similar question to, sorry, James.
Just to add to that, because obviously, if you're looking at just symptoms alone, you will miss complexity as well. So a really simple example for clinicians on the call, if you've got some significant background health, if you're on biologicals or you're immunocompromised and you present with a sore throat, you're a very different person to a young student with a sore throat. And it's understanding how we can appreciate those two different symptom group types based on information that's coming elsewhere into the system, whereas a symptom tree algorithm won't do that. It won't look at other pieces of the patient history to determine what the outcome is, if that makes sense.
Super. And Dom, kind of a similar sort of question to you, looking at Tortoise and the medical device certification. What does that mean in an AVT? Why is that important? Does that have something to do with knowing medical terminology? Is it something to do with hallucinations? Why is that something that clinicians should be looking for?
Yeah, I think the best way to describe it to a layperson is it's like any medical device certification is not about what it does, it's what you intend it to use. So it's the intended use that's critical. So we are also doing our audit to go through to Class 2. And the reason for that actually is because it fundamentally does influence your diagnosis treatment. It's not as overt potentially as like actually giving you a diagnosis, but we've certainly had, mostly in the positive, people say, oh, I forgot about that, but it was in the note. Now that is a positive influence on the change of the management of the patient because they mentioned a condition, you were going to forget about it in management, you decided that you're going to manage it instead. And also the corollary of that is the potential for negative impacts. So hallucinations, for example, what we've seen now with like quite a breadth, about 2 years of experience in the NHS, is it's not necessarily the clinician in front of the system that you need to worry about. They're in the loop. It's actually the next clinician. So if you find hallucinations or omissions or added data that's erroneous and it gets incorporated into the record at that instance, we currently have no way of knowing that that's human text or AI text. And once it's in the record, it's in the record. And there was a case some of you may have seen very publicly in the US from another company in this space. An entirely generated note appeared in the system and fundamentally actually started changing patient management. So for those two reasons, as Hannah says, like Class 1 doesn't really mean very much. It's a self-certification. You could have done the work, you might not have done it. But Class 2 is a notified body going through your work and like putting you through the ringer to make sure that what you say and what you claim and what you intend about your software is actually the case. And that's why we've decided to go down that route and have been on that journey for about 1.5 years now.
Thanks, Dom. The chat's going a bit wild, and I can see a lot of questions have been answered in the chat. And I'll be really honest, I'm losing a bit the thread of what hasn't been answered yet. But one thing I did write down that was from quite early on was someone asked about what the experience has been of the pathway change. So this is probably more of a question for James and Ahmed. How that pathway change was implemented. Did people resist? Were they eager to use it? And how has it been?
Shall I jump in? So we only had a limited number of microphones, so obviously recruitment was quite straightforward. Everybody was enthusiastic about using this. So, like I said, the first couple of weeks, well, people were finding the best workflows. This has never been used in an ED on a mass scale before, so we were all learning on our feet. But like I said before, I think it was very quick for us to work out our own workflows, considering the diverse patient presentations that we have, as well as the environmental challenges that we have. So that goes back to how we deploy this well on a mass scale. It's just going through those key areas. I do not think it requires a huge amount of resource and training, but it does need to be done really well. So yeah, I think the workflows are not too dissimilar to our just normal day-to-day thing. The good thing about this technology, it's not difficult. You don't want to give any clinician a tool that is challenging, that it's fiddly, because people will find that frustrating, particularly with ED clinicians, because we're very much on the go, crack on with it, go through the patients quickly. So, that the fact that it worked so well is testimony that the workflows are not too challenging.
Yeah, and Carla, from our point of view, I couldn't agree more with what Ahmed said, by the way. Implementation in the NHS is really difficult, and you have to start small. You have to assure that your clinicians, your systems, your governance structure, that you're doing the right thing. So we reviewed all the as many cases as we could each week, and looked at outcomes, looked at sort of experiences of patients, etc., on a small scale. And it's just doing that is really key. But to anyone who's implementing something in the NHS, this kind of thing is very different in an ED setting. Everyone always talks about it has to integrate and it has to be easy, or else forget it. And I totally get that and agree with that. This is slightly different when you're trying to look at a service that's already offering so many calls, etc. And it's understanding the outcome-based stuff that Hannah alluded to. There's a lot more to it than that. I mean, we don't really know what a lot of the time when patients get ambulance outcomes and they're inappropriate, there's a lot of activity that happens that is wasted. And the more we can get people into the right setting, that in that first time, and see that they're not reconnecting to alternative services within the next 72 hours, we know then, and we're looking at doing research into that in the future, and that will really give us all strength to move forward with it.
And have any of you done any economic impact analysis and found cost savings from uses of these technologies?
Yeah, so as part of the Pan London trial, you may have seen the press coverage last week. I think it was the Yorkshire group that did an independent economic analysis. It's included in the paper, and I can share that in the chat. It was also in the 10-year plan, as it happens. I think the modelling is just under £1 billion of savings for deployment in every A&E in the NHS, which is a combination of productivity and reduction in locum costs as well. I'll share that in here and people can take a look. It's always, the proof is in the pudding though, because you can model out mass NHS A&E deployment, but that's the hard bit, right? Getting people to use it and actually make that work is the tricky piece. The technology is there, but if people only used it, that's great. But like, how do you actually get them to do that? So one of the things that we say, for every unit of energy it takes to build an AI technology, it takes 10 units to evaluate it for safety, for accuracy, and 100 units to implement it. So we're very much at sort of just figuring out that evaluation stage, and then the implementation and the scale up is what we'll probably be doing for a couple of years, and then we'll see what the value really is.
From a VC perspective on the health economics, I mean, this is really interesting for me personally, because coming into this pilot, I really thought the exciting piece was, okay, let's reduce, will this be able to, can we show that this reduces A&E attendances and ambulance deployments, etc. And that work we had modelled by, it was independent health economics valuation, £10 million a year across London cost savings, 340 million scaled across England, projected, as Dom said, quite hypothetical, but all really exciting. Actually, the thing that the ICBs clung to was the fact that we took people away from call handlers, and therefore IUC contracts for the first time were going to be a little bit cheaper, because there was a way of routing people away from potential phone line waits. So the data's there. It feels like maybe that's a little bit, at some point in the future, that will be revisited, I think, but the immediate opportunity seems to be just quite literally taking people away from phone queues, which I understand, because that's, I think, been challenging for all providers.
Thanks. And we're getting close to the end. And while Emily's popping up the slide, we've got some QR codes if anyone would like some more information about the Health Innovation Network. I'm going to put you on the spot because I didn't warn you. If you want to come up maybe with a one sentence sort of takeaway from each of the pilots, kind of your experience or what you think the important learning bit is as we wrap up the call. Does anyone want to volunteer to go first? You could probably have 2 sentences if you want. Oh, and we've got a poll on screen for people to answer just about the webinar and their experience today. So who's feeling brave and wants to come up with their one takeaway?
I'd just say, for innovation like this, you need to be brave, bold, and get people on board and believe in it.
Super, thanks.
I think for me, it's perseverance. If you want to make change, you have to keep annoying the powers that be to get your thing done in the NHS.
That's great advice. Thanks. Dom or Hannah?
I think for me, it's actually about safety. So the technology will keep getting better in the AI space over time naturally. But like, what is really differentiated for enterprises, is it safe and does it actually work in that specific clinical environment? And that's, as I said, the hard bit, but that's where all the value lies.
Great.
Yeah, I would agree on the safety. I would say the thing to really understand about AI technologies is where the clinical liability sits. And there has not yet been any case law where AI tools have interacted with clinicians and there's been liabilities really been contested. So that's worth really understanding. And again, happy to talk about it because we've spent a lot of time back and forth on that.
Fantastic. Thanks. I'd like to thank all of our presenters today. Dr. James Ray, Dr. Ahmed Mahdi, Dr. Don Pimenta, and Hannah Gibson. I think we spent a really good hour talking about this AI technology. We've got the links on screen if you'd like to get in touch. If you'd like any more information about Visiba or about Tortoise, you can, if you want to put your contact details in the chat or contact us via our website, we can put you in touch and get you all the information you need. I'd also like to thank Emily and Annie for running furiously in the background and making the webinar look fantastic. So thanks everyone for attending, and we'll see you at the next Health Innovation Network webinar.